The title of this talk I stole from a 1966 Western film starring Clint Eastwood, and hopefully the significance of the title will become clear by the end of our webinar. So no conflicts of interest to declare. So in terms of learning objectives, I think it's quite important to begin with a definition of terms. Next, I'll go through sort of 4 key biologic principles of clonal hematopoiesis. Then we'll discuss the relevance of clonal hematopoiesis as a pre-malignant state, and very importantly, how to distinguish between lower and higher risk states. We will then discuss the surprising non-malignant health consequences of clonal hematopoiesis. And last but not least, we'll discuss a practical approach to managing individuals identified with clonal hematopoiesis in the absence currently of any consensus clinical guidelines or approved preemptive interventions in North America or otherwise. So a bit of history about the field of clonal hematopoiesis. In the mid-90s, it was the first time it had become appreciated that there's hematopoietic oligoclonality in healthy individuals, when it was noted that over 40% of women over the age of 60 actually harbored X chromosome inactivation skewing greater than a ratio of 3:1. Then in 2012, it was noted that older women with the same phenomenon, 5% of them actually harbored TET2 mutations, which is an epigenetic regulator recurrently mutated in both myeloid and lymphoid malignancies. In that same year, it was also noted that healthy adults harbor mosaic chromosomal copy number abnormalities, for example, trisomy 8. However, the current field of clonal hematopoiesis really took off in 2014, where there were 3 high-profile publications from 3 groups that independently had used next-generation sequencing from existing data sets in studies that were conducted for other reasons originally to demonstrate that clonal hematopoiesis is actually quite prevalent in the aging population, and I should say the healthy aging population. And in these sort of unselected populations, that the presence of clonal hematopoiesis was associated with a 0.5 to 1% risk per year of progression to a bona fide hematologic malignancy. But the very surprising finding was this association of clonal hematopoiesis with an increased risk of all-cause mortality that primarily was driven by the advent of ischemic cardiovascular events. And that was a truly unexpected finding. So I think clear definitions is quite important because often these terms are used imprecisely. So the broadest term is clonal hematopoiesis, and that simply refers to expansion of hematopoietic cells from a single common ancestral hematopoietic stem cell. And this term is agnostic to the underlying sort of genetic marker of clonality, as well as the size of the clonal population. The next sort of broadest term is age-related clonal hematopoiesis, or ARCH. And this refers to a form of clonally restricted hematopoiesis in which the genetic markers are recognized as being recurrently mutated or involved in hematologic malignancies. But again, this is occurring in an asymptomatic population. So no formal definition of a concurrent hematologic malignancy. Then CHIP, or clonal hematopoiesis of indeterminate potential, which I would like to rename as emergent potential, so CHIP. This is a specific form of ARCH in which we're referring to recurrent somatic, mostly point mutations, in which specifically there's a variant allele frequency greater than or equal to 2%. So for heterozygous mutations, roughly 4% of cells will be carrying this mutation at that burden. And now this 2% variant allele frequency cutoff was originally a technically derived definition. Its origin was that this, at the time, for error-corrected next-generation sequencing, was sort of the limits of fidelity. But fortuitously, it has since been discovered that this VAF cutoff of 2% is also likely a clinically relevant cutoff. And then CCUS, I think of it as the equivalent of smoldering multiple myeloma, whereas CHIP is like MGUS. So with CCUS, this is where we have CHIP, or not to forget, in addition to somatic point mutations, we can't ignore that there's also actually mosaic chromosomal alterations. So again, deletions, duplications, or even copy number neutral loss of heterozygosity that are associated with bona fide hematologic malignancies. So for example, trisomy 8 in MDS. And so CCUS is where there's now, and very importantly, otherwise unexplained cytopenias. So there has to be an exhaustive investigation for alternative etiologies for the cytopenias that are therefore causally associated with these underlying either recurrent somatic mutations or chromosomal alterations. And I have here the arrow going downwards for clonal expansion, which is really just the selective propagation of the affected clone. And this is due to an interaction between the intrinsic properties of this affected clone and extrinsic selective pressures. But it's not unidirectional entirely. So I do have a small arrow showing regression. So if these sort of external selecting forces are altered, in theory, the clone could shrink. And probably the nicest example of that is if you have a patient, for example, with DNMT3A and NPM1 mutated AML, they undergo induction chemotherapy, and in the post-remission sample, you're still picking up on the DNMT3A mutation, then in theory, you've knocked this patient back from a state of AML to clonal hematopoiesis. So that's one sort of straightforward example of how this arrow may not be entirely unidirectional when it comes to clonal expansion. So a few caveats, though, to this paradigm. We've already spoken about the 2% VAF cutoff as really being a technical threshold. The next, though, is that this paradigm does not account at all for oncogenic fusion transcripts, such as those that define CMML or Burkitt's leukemia or lymphoma, because in this case, these sort of oncogenic fusion events are actually quite powerful in their own right, and often can result in leukemogenesis in the absence of sort of additional stepwise cooperating events. And so they're really not captured in this paradigm at all. And the other thing to keep in mind is the confounding impact of deleterious germline mutations, which actually in the absence of concurrent germline tissue sampling, sometimes it's impossible to distinguish from a somatic mutation in that same gene. Although a near heterozygous VAF of near 50% is often the clue. So the idea that there's genetic diversity or somatic mosaicism in cells of any given tissue is not a new concept. This has been known for decades, and nor is it news that polyps are a precursor state to colorectal cancer. So, what makes hematopoietic somatic mosaicism special compared to this in other tissues? Well, one is just hematopoietic tissue is the most easily accessible and therefore the most ubiquitously sequenced. But the other really important thing is that the blood system is a mobile tissue. And by virtue of that, in the event of clonal hematopoiesis, you have these aberrant hematopoietic cells coming into constant contact with other tissues within the body. And most prominent is the vascular endothelium. And then that ties in to that surprise association in 2014 with clonal hematopoiesis and accelerated cardiovascular disease. And this quote here, which roughly translates from Latin to "who will guard the guards themselves," refers to how can we hold power to account when the enforcers themselves are corruptible. And another unique thing about clonal hematopoiesis is that the hematopoietic and immune system are two sides of the same coin. And so you have a portion of the immune system that's responsible normally for cancer surveillance that in its own right has gone rogue in the event of clonal hematopoiesis. And so this has implications for immune privilege in terms of allowing the clonal expansion, but also for associated autoimmune manifestations in clonal hematopoiesis. And a very striking example that has recently been published is this clinical syndrome called VEXAS syndrome. So now to the sort of 4 fundamental principles of clonal hematopoiesis. So one is that clonal hematopoiesis is age-related, or at least the detection of it. And so if you make the cutoff of variant allele fraction of 2% or more, less than 1% of persons under the age of 40 are going to have clonal hematopoiesis, at least to this extent. But over the age of 70, then you're going to be picking it up in sometimes up to 20% of an unselected aging population. And the caveat, though, to the fact that clonal hematopoiesis is age-related is that this is highly dependent upon the sequencing depth. And so there was a groundbreaking paper that actually came out of the Sanger Institute on your end that looked at 12 patients with myeloproliferative neoplasms and then used phylogenetic modeling to make the case that this underlying JAK2 mutations might actually occur extremely early in life and possibly in utero. And furthermore, there was deep sequencing done from the Washington University group, and they actually sequenced umbilical cord leukocytes from infants and likewise picked up on up to about 18% of clonal hematopoiesis when you did ultra deep sequencing in umbilical cord leukocytes. So the age-related phenomenon is somewhat dependent upon depth of sequencing. And then here on the right-hand side, we have an amalgamation of those 3 groundbreaking papers from 2014 showing the age-related prevalence of clonal hematopoiesis in these sort of unselected aging populations. And the next very important concept is that clonal hematopoiesis and inflammation share a reciprocal relationship, or a pernicious cycle, as was recently written in a New England Journal of Medicine editorial about this phenomenon. And so it's actually been characterized in a number of preclinical models that TET2 mutated clonal hematopoiesis in particular leads to strong upregulation of interleukin-6 signaling through the NLRP3 interleukin-1 beta inflammasome axis, and that this inflammation in turn favors expansion of these TET2 mutated clones. And then on the right-hand side is a recent publication in Science from a Boston children's group that they actually used a zebrafish model of ASXL1 mutated clonal hematopoiesis, in which the ASXL1 mutated hematopoietic stem cells, here in red or pink, gave rise to ASXL1 mutated neutrophilic monocytic progeny that in turn had upregulated inflammatory signaling that in general was deleterious to the wild type hematopoietic stem cells, but the ASXL1 mutated hematopoietic stem cells actually concurrently had upregulation of defenses that allowed them to resist the normally deleterious effects of this pro-inflammatory milieu, that therefore in turn favor the clonal expansion of these stem cells, and then in turn expanding the hematopoietic stem cell progeny. And so again, this really is just emphasizing at a preclinical level how much of a feed forward loop this is. Although the exact kind of mediators and consequences of this are likely to some extent mutation specific. So the next important concept of clonal hematopoiesis, especially clinically, is that the most prevalent mutations seen in clonal hematopoiesis, so primarily these epigenetic regulators, DNMT3A, TET2, ASXL1, closely followed by mutations in JAK2 and TP53 and spliceosome members. They tend to be on their own fairly weak malignant drivers, and really additional cooperating events are required for leukemic transformation to occur. And this often involves activating mutations in the FLT3 or RAS-MAP kinase pathway signaling players. And again, the caveat are these powerful oncogenic fusion events, for example, MLL rearranged, AML and ALL. That's totally outside of this paradigm. But within this paradigm, if there really is sort of the stepwise acquisition or progression, it also means there's an opportunity for early intervention, possibly. So the final fundamental principle of clonal hematopoiesis is that the clinical implications of it are highly context specific. It depends upon the underlying driver mutation or chromosomal alteration. It's also effector cell specific. So most of the preclinical research has focused on mutated myeloid precursors, primarily monocytes and macrophages, with underlying DNMT3A or TET2 mutations. So very little is known about the impact of other mutations in these models, let alone other effector cells. Although there does appear to be a differential survival benefit depending upon the effector cell. So even though the mutation occurs at a stem cell level, even if that mutation favors expansion of monocytes and macrophages from this ancestral clone, it may actually be deleterious to the B and T lymphocytes coming from the same ancestral clone. And finally, probably the most critical point for clinical practice is the role of cell extrinsic effects. So the expansion of clonal hematopoiesis involving mutations in the DNA damage response pathway, so TP53 and PPM1D mutations, for example, really only occurs in the face of additional genotoxic stressors. And so this is why I have this photo on the right-hand side of the Darwinian finches and their various beaks, with the underlying concept being that these finches were all allowed to occupy one ecosystem because their beaks allowed them to specialize very differently for food sources. And so any given external selective pressure is going to have sort of a different impact on the various forms of clonal hematopoiesis and vice versa. And so, for example, when we look at clonal hematopoiesis in patients with underlying immune-mediated bone marrow failure, such as aplastic anemia, we see a favored clonal expansion of very different forms of clonal hematopoiesis, and often ones that give advantage in terms of stem cell renewal, but also immune evasion. So, for example, the PIGA somatic mutations is a perfect example of that, or certain loss of HLA alleles. So shifting to, how do we apply this to clinical practice? Well, there's really two goals to always keep in mind. And one is to prevent the progression of these precursor malignant states to avert hematologic malignancies, usually myeloid, but transformation to lymphoid malignancies is quite possible. And so for unselected populations, and it's actually eerie how similar this is to the cumulative risk of progression for standard risk MGUS, but likewise for the myeloid equivalent of MGUS CHIP, that risk of progression is roughly 0.5 to 1% absolute risk per year. And in this beautiful book by actually an MDS specialist that works in New York, Dr. Azra Raza, I love this quote: "To begin the ending, we must end the beginning." And when it comes to cancers that we can cure with preventative medicine, it so far has been ones where we pick up on a precursor state and we cut it out. And the blood tissue is liquid, so that's not possible. But can we do something analogous if we're able to identify high-risk precursor states? And the second, perhaps even more important goal to studying and eventually intervening upon clonal hematopoiesis is to actually mitigate the extra-hematologic consequences, primarily the adverse cardiovascular events, which from a population perspective are much more prevalent. Whereas only less than 5% of patients with clonal hematopoiesis will ever go on to get a subsequent hematologic malignancy, a much higher percentage of the clonal hematopoiesis population will develop some form of cardiovascular disease. The challenge, though, is that right now there's a complete absence of prospective surveillance, let alone intervention trials to sort of guide this clinical management. So at this point, we're flying blind. Hence why we should operate right now on the basis of these 4 principles. So here at MD Anderson, we've just started a formal clonal hematopoiesis or precursor clinic. And here's an example of some of the referral streams. And each underlying referral stream for affected individuals has a very different associated risk of subsequent hematologic malignancy. And what you will see will very much depend upon what kind of center you work in. So for the general hematologist, probably the most common form of clonal hematopoiesis that you're going to see a referral about is for a CCUS, where you have an isolated cytopenia. Usually it's isolated anemia in an elderly patient, and you proceed with an underlying bone marrow biopsy, and the morphology is insufficient to support a diagnosis of MDS at this time, for example. Another that we see quite commonly here, because I operate within a cancer center, is that you have patients that are undergoing chemotherapy or radiation for a solid tumor, and then demonstrates a delayed hematopoietic recovery. And they never quite recover their counts to the pre-treatment levels, and then you pick up on an associated clonal mutation. But other referral streams is if you're performing sequencing in the face of another hematologic malignancy, so in the lymphoid world. It's not uncommon at all to have a patient with myeloma that undergoes sequencing, and then a TET2 mutation with a VAF at 10% is picked up. And what do you do with that? For solid tumor NGS sequencing, I didn't understand this until recently, that because solid tumor samples are almost always contaminated with blood, they usually do concurrent sequencing of the peripheral blood along with the solid tumor sample, and then use mutations picked up in the peripheral blood actually to filter out the sequencing on the solid tumor. But now inadvertently, you're picking up on clonal hematopoiesis in the peripheral blood, even though you're using it initially just as a sort of filtering factor. And this is becoming more common as that somatic variants are being picked up in germline testing. So for example, the NVTA germline sequencing panel in the report will actually put out in a report a section where they pick up on potentially pathogenic somatic mutations and recommend that these are followed up. The cell-free DNA sequencing technology is rapidly expanding, and this now is making sort of solid tumors sampled as if they're peripheral blood. But in that process, we can be picking up inadvertently again on clonal hematopoiesis. And last but not least is a very debatable area. But at some centers and under some circumstances, they are performing NGS sequencing in donors for allogeneic stem cell transplantation. And so what do you do with that once that's picked up in the donor? So this is a very practical paper that I came across from the Dana-Farber Cancer Institute. And the question is, does every patient referred to you with an unexplained cytopenia require an initial bone marrow biopsy? And so what they did is they applied their standard NGS somatic sequencing panel to patients referred to Dana-Farber for unexplained cytopenia or cytopenias. And they then looked at, of these patients that had it performed on the sequencing on the peripheral blood, what percentage of these patients went on to be found to have a bona fide hematologic malignancy, and whether that patient got a subsequent bone marrow or not was up to the practitioner, who was entirely blinded to the results of the peripheral blood next generation sequencing. And the bottom line was, when it came to the operating heuristics of performing peripheral blood NGS sequencing in such patients, was a bit like the utility of a D-dimer test when it comes to detecting pulmonary embolus. Essentially, if the NGS panel was clean, it had a very strong negative predictive value for this patient in the ensuing 6 months or so to go on and be diagnosed with a bona fide hematologic malignancy, whereas the positive predictive value was pretty equivocal. So I think this is quite valuable, that if the peripheral blood NGS is clean, it's unlikely that that patient really does need a bone marrow biopsy to investigate further. But if somatic mutations are picked up, then it's likely unavoidable at this time to perform a bone marrow biopsy. And then in terms of on that peripheral blood NGS, what heuristics were the strongest predictors of being associated with an underlying myeloid neoplasm? It was as you expect. If the variant allele frequency was high, so above 20% in this case, if 2 or more pathogenic mutations were picked up, or if any spliceosome mutation was picked up on the NGS panel, these all correlated with the patients likely having an underlying myeloid neoplasm picked up. But these operating characteristics actually held when they limited the NGS panel from 95 down to 10 genes analyzed. So I don't know if anybody's seen the movie The Minority Report and the significance of the precogs, but the concept of this film that starred Tom Cruise was that they had these precogs that were, in theory, able to predict which citizens were going to commit crimes in the future so that the police force could actually arrest the future perpetrator ahead of time. And that's the hope that we can do it someday with clonal hematopoiesis. And so there were two nested case control studies from 2018, one from an American group on the left, another from an Israeli group on the right. And they looked back at existing large-scale databases that, again, existed for other reasons. So, for example, with Desai et al., it was using data from the Women's Health Initiative. And they looked at patients from these registries that went on to have an ICD code for AML, and then looked back and sequenced their original peripheral blood samples to look for hematologic malignancy associated mutations or clonal hematopoiesis. And they were able to build somewhat of a prediction model for what sorts of clonal hematopoiesis actually predict for AML risk, with a follow-up ranging roughly between 7 and 10 years. And they actually were reassuringly concordant in what they found in terms of what constituted high-risk clonal hematopoiesis in terms of AML risk. They unfortunately were unable to do a similar analysis for MDS because at the time of enrollment of some of these patients in these registries, MDS actually didn't have an ICD code for them to link with. But the bottom line was that if any clonal hematopoiesis was picked up, you had an odds ratio of developing AML of just under 5. And in terms of the highest risk specific mutations associated with AML risk, was not surprisingly TP53, mutations in IDH1 or 2, any spliceosome mutation, RUNX1, and then for DNMT3A and TET2 and ASXL1, that was really more if multiple mutations were found in these genes, or if it was a DNMT3A or TET2 mutation plus other affected genes, so combinations. And in the Desai et al. Paper, they actually suggested some higher risk specific combinations. And so again, seeing SRSF2, so a spliceosome player, plus any of the underlying epigenetic regulators, or the combination of a RUNX1 and PHF6 mutation, were the most strongly predictive of AML risk. And the Israeli case control study was quite similar, with the exception that they highlighted the spliceosome player U2AF1 mutations at particularly high risk. And they highlighted ASXL1 as associated with increased risk of AML, whereas IDH2 mutations were not in their cohort. They also actually noted that an elevated red cell distribution width was also predictive. And interestingly enough, this Israeli group also built a machine learning model where they looked at just basic clinical parameters. So really just the CBC and red cell indices, and they were able to come up with a rudimentary risk prediction model that predicted developing AML within a 6 to 12 month period, just based on those indices alone. And some additional notes to point out for both of these studies, as you would expect, if there were the higher the VAF in the underlying mutation, or combinations of clonal hematopoiesis, all of these had higher predictive risk. Interestingly enough, for some in the Desai et al. Paper, they actually were able to serially sample some of these mutations. And if there was a rapid rise in TP53 or IDH2 mutated clones, that was also associated with a shorter time to AML development. So there's definitely a dynamic aspect of this as well. And so this is a risk prediction model that was built by an Italian group looking at predicting myeloid neoplasm risk in patients with clonal hematopoiesis over the age of 80 years. And in this study, they actually used a VAF cutoff of 1 and not 2%. And about a third of their patients over the age of 80 actually had clonal hematopoiesis with this 1% VAF cutoff. And a bit similar to the IPSS risk score, they actually were able to build risk prediction groups at low, intermediate, and high risk of subsequent myeloid neoplasm based on this model. And they inadvertently also picked up on the fact that there's a mutation signature that, instead of being predictive for subsequent myeloid neoplasm in this elderly population, was actually predictive of inflammatory disease, including rheumatoid arthritis and coronary heart disease. And so in terms of the two kind of high risk mutation signatures for these respective outcomes, quite similar to the case control studies from the last slide, is that if you had any splicing gene mutations, if you had variant allele frequencies just above 10%, or if you had these epigenetic DTA mutations in combination with other forms of clonal hematopoiesis, that was sort of most predictive of subsequent myeloid neoplasm development. And in contrast, if you had mutations in these epigenetic regulators or in JAK2, this was actually a signature predictive of these inflammatory outcomes. And this is a study from the Netherlands with fairly similar findings, also looking at patients exclusively 80 years and above. And the thing to point out here is that they actually built a competing risk of death model. Because often the argument is, if you find clonal hematopoiesis in somebody over the age of 80, well, they're likely to die of other causes. So, why study this? Why follow this in this patient? And when you look here at the hazard ratios for any given point mutation, again, spliceosome mutations did have a significant association with risk of death. And then there were trends for TP53, JAK2, and ASXL1 mutated clonal hematopoiesis. And when you look, what was driving this risk of death? Well, red here is death from hematologic malignancies. And if you look at the population without and with clonal hematopoiesis, you do see this slight sliver of red appear. So at least for some of these mutations, that risk of death, even in this very elderly population, is seemingly driven by death from hematologic malignancy. So CCUS, or clonal hematopoiesis, or clonal cytopenias of undetermined significance, it sits at the borderlands between CHIP and then a bona fide hematologic, usually myeloid neoplasm, and often with the only difference being in these cases that morphologically you actually start to see dysplasia to call this MDS. Although I do anticipate just how the definition of smoldering multiple myeloma actually changed in 2014 based on the fact that there were certain conditions that were not being called multiple myeloma that did predict an 80% risk of progression to multiple myeloma. They decided that clinically it made sense just to reclassify these patients as having bona fide multiple myeloma warranting intervention. And I suspect for some of these cases of CCUS one day, the WHO diagnostic manual might actually change to reflect that and possibly not require necessarily that burden of dysplasia to be seen before calling this, for example, lower risk MDS. But that's just my speculation. So there's no formal VAF cutoff in CCUS, but really to believe that the cytopenias are driven by this clonal process, you do have to have a certain degree of clonal burden to believe that the two things are causally linked. So it's been proposed in one editorial that we use a VAF cutoff of 20% or more to say, for example, that an underlying TET2 mutation is the main cause of a given person's, let's say, isolated macrocytic anemia. And again, when you look at what are the predictors of high-risk CCUS, i.e. those cases most likely to go on to become MDS or AML, again, it's a VAF above 10% or multiple mutations that are most predictive. And if you have a dominant clone with a VAF greater than 20%, this is associated with a 95% risk of progression to a bona fide myeloid neoplasm within a decade. So again, should we one day call these instead smoldering myeloid neoplasms? I don't know, but I propose it's a thought. And so this is a really practical retrospective study from the Mayo group. They as well have now a clonal hematopoiesis or precursor program, and they compared 75 patients with CCUS to sort of matched cohorts of patients with low-risk MDS or low-risk chronic myelomonocytic leukemia and compared their characteristics and outcomes. And so you see here in the blue on the left is the mutation frequency in these genes in the CCUS cohort. And then on the right-hand side is in the lower risk MDS cohort, fairly comparable with the exception that SF3B1 mutations were highly enriched in the lower risk MDS cohort. But what I found quite striking is that of the patient cohort with CCUS, almost a quarter of them were red cell transfusion dependent, and more than 10% were platelet transfusion dependent, which is almost a worse clinical state than a lot of cases of lower risk MDS. And interestingly enough, if you extrapolated the the revised IPSS criteria from MDS and applied it to the CCUS cohort, 13% of patients actually met the criteria to be intermediate risk per this. Again, probably reflected by these fairly clinically significant degrees of cytopenias. And interestingly enough, some of these patients were treated essentially as if they had lower risk MDS with transfusions, growth factors, and there was even 1 or 2 patients treated with hypomethylating agents. But on the right-hand side, when you look at overall and leukemia-free survival, there really was no statistically significant difference between the patient cohort with CCUS versus lower risk MDS. So this goes back to the Finch beaks and how certain forms of clonal hematopoiesis really are only clinically relevant in a given sort of extrinsic stressor or selective pressure. So when it comes to therapy-related myeloid neoplasms, which have relatively abysmal outcomes relative to de novo myeloid neoplasms, they often arise from the expansion of pre-existing clones in genes involving the DNA damage response pathway. And this is a huge paradigm shift because for a long time it was thought that therapy-related myeloid neoplasms and the associated mutations in these DNA damage response pathway genes was due directly to the mutagenic or genotoxic effects of the therapies themselves used for treatment of the solid malignancy. But there was a case control study actually conducted here at MD Anderson by Dr. Takahashi, where he looked at patients that went on to develop therapy-related myeloid neoplasms and then sequenced their pre-treatment samples prior to treatment for solid tumors or diffuse large B-cell lymphoma respectively. And he was able to demonstrate that the vast majority of patients that developed therapy-related myeloid neoplasms, that their underlying mutations, often in TP53 and PPM1D, did pre-exist prior to their exposure to their therapy for their lymphoma or solid tumor. And really there was just clonal expansion following those genotoxic exposures. And moreover, that there was a dose-dependent relationship between these exposures and subsequent therapy-related myeloid neoplasm risk. And really important is that if you look here on the right-hand side, this is from Sloan Kettering data that initially was looking at sequencing solid tumor samples, but took advantage of the concurrent peripheral blood sequencing and noted this association between mutations, again, in these DNA damage response pathway genes and prior history of, in particular, ovarian and breast cancer. And they realized that this was driven by clonal expansion in response to certain genotoxic exposures, primarily platinum chemotherapies and topoisomerase II inhibitors. And so this is expanding on the Sloan Kettering data, again, with respect to future risk of therapy-related myeloid neoplasm. when you pick up on underlying clonal hematopoiesis prior to solid tumor treatment. And when you look here on the left-hand side at this essentially forest plot, again, things that carry the highest odds ratio of subsequent therapy-related myeloid neoplasm, or if there was pre-existing red cell abnormal indices, so an elevated MCV or RDW, if you had mutations primarily in spliceosome or DNA damage response pathway players, and or elevated VAFs. And then here on the right-hand side, they've actually, the Sloan Kettering group, and it was Kelly Bolton that since has moved on to Washington U, they've built a very preliminary, so it's not for clinical use, risk prediction model where they looked at women with breast cancer at highest risk of therapy-related myeloneoplasm based on these heuristics on the left. And they looked at the absolute risk reduction of subsequent therapy-related myeloneoplasm if these women forego adjuvant cytotoxic chemotherapy versus not. And then likewise, similar work has been done at Baylor here in Houston when they look at the PPM1D mutation, which is mutated in 20% of therapy-related myeloid neoplasms. So here on the left-hand side, they looked at therapy-related myeloid neoplasms with and without PPM1D mutation and looked at factors that were associated with expansion of the PPM1D mutation. And again, it was only specific sort of genotoxic interactions, primarily exposure to platinum and topoisomerase II inhibitors again. And this was replicated in an in vivo sample where they showed a PPM1D model of clonal hematopoiesis only expanded under certain chemotherapy exposures. So this next summary table, I really want you to interpret this with caution. This is just sort of how I now risk stratify clonal hematopoiesis in clinic and potential actions that can be taken in response to that. And this is where the title of my talk, The Good, the Bad, and the Ugly, comes in terms of moving from lower to higher risk clonal hematopoiesis, primarily with respect to risk of subsequent hematologic malignancy. So what I call the quote unquote good-ish clonal hematopoiesis is that where the VAFs are relatively low, and these are isolated mutations in the epigenetic regulators DNMT3A or TET2. And in here, really the greatest risk for most patients in this situation is that of associated cardiometabolic disease and its acceleration from the underlying clonal hematopoiesis. So for most of these patients, I think the most important thing is that you closely scrutinize their traditional cardiovascular risk factors and try to modify what you can. I think it's unlikely that these patients need a bone marrow biopsy. And this is one of the scenarios where you can perform peripheral blood next generation sequencing if you wish. Sorry about that. And I think these patients primarily are ones that probably do not need longitudinal follow-up and dedicated clonal hematopoiesis or precursor program. So a bit like standard or lower risk MGUS, where these patients can be sent back to their primary care team and really be re-referred only in the event of changing blood indices. And then the bad, this is where the risk of subsequent hematologic neoplasm is elevated enough that I do think it's warranted that they are followed longitudinally in a clonal hematopoiesis or similar clinic. So these are patients where they have the DNMT3A or TET2 mutations, but in combination with other mutations, or they have non-DT mutations, or they have aneuploidies. So again, we can't forget about the mosaic chromosome alterations other than -Y, which is a pretty kind of normal population finding. And then additionally, letters A through E outline sort of mutations where there's some sort of specific clinical action that potentially can be taken. So in this category, I do think that most of these patients would benefit from a baseline bone marrow biopsy to make sure we're not missing already underlying myeloid neoplasm. I do think it's worthwhile to repeat the sequencing, at least on the peripheral blood, to assess longitudinal clonal dynamics. And I do think it's worthwhile to do a repeat bone marrow biopsy should there be any change in their peripheral blood indices in the future. And then when it comes to mutation-specific interventions, ASXL1 mutations actually tend to be most deleterious or expand most favorably in patients that smoke. And so actually, I think the number one clinical intervention you can make here is advise patients to quit smoking. There isn't really the time to show this data, but there is an association between having JAK2 V617F clonal hematopoiesis and the elevated risk of venous thrombosis, even the absence of a overt myeloproliferative neoplasm. So in these patients, I aggressively manage cardiovascular risk factors. I consider giving them prophylactic low-dose aspirin if their bleeding risk is low. I consider actually adding a statin if they aren't already on one. And I definitely educate them about how to recognize clinically a DVT or PE. And then IDH1 and 2 mutations should be highlighted for two reasons. One is that they do have a high relative risk of subsequent hematologic malignancy. But two is that they're targetable with FDA-approved therapies that have been approved at least for use in MDS with these underlying mutations. And so there's actually two clinical trials. I've only listed one here, but there's actually two clinical trials now, one run out of the Mayo Clinic, one led by Sloan Kettering, where they're applying ivosidenib and enasidenib respectively, the IDH inhibitors, for patients with IDH1 or 2 mutated clonal hematopoiesis, but in the CCUS state. So they have to have an associated peripheral blood cytopenia, and with the primary endpoint actually being reversal of that cytopenia or restoration of normal peripheral blood counts. Spliceosome mutations definitely carry one of the highest risks of subsequent hematologic malignancy. They are not currently druggable, but hopefully one day will be. And in particular, I just wanted to highlight the combination of a TET2 and SRSF2 doublet mutation. This is most predictive, the most predictive genetic signature for developing subsequent CMML rather than MDS. And then CCUS, just by virtue of having a causally associated cytopenia, these are at kind of highest risk, more akin to a cumulative risk of 10% per year developing a hematologic malignancy. So I'd approach these patients based on that Mayo Clinic series, very similar to lower risk MDS in terms of surveillance, frequency of bone marrow biopsies, and even in supportive care. And then the final category, the ugly. So these are mutations that either I consider to be equivalent to incipient AML. So I don't think there really exists a state of clonal hematopoiesis when you find the underlying NPM1, FLT3, or mutation in a RAS/MAP kinase player. I think because these tend to be late leukemogenic events and often associated with leukemic transformation, if I pick that up, I essentially would treat that patient as if they already have a bona fide hematologic malignancy, because that time to AML transformation would be extremely short if they don't already have AML. But then the ugly are these DNA damage response pathway mutations that underlie a lot of the adverse prognosis of therapy-related myeloid neoplasms. So the important clinical point here is that these mutations, in the absence of those specific genotoxic stressors, can be stable. But I would actually watch these patients fairly closely because of how poor the clinical outcomes are once a therapy-related myeloid neoplasm develops. So first of all, you want to exclude any underlying germline etiology, especially if the VAF is near heterozygous. We at MD Anderson have picked up on a few cases of Lee-Fermani syndrome in patients that were initially referred for TP53 mutated clonal hematopoiesis. Ideally, you coordinate with their solid tumor oncologist to try to minimize any unnecessary genotoxic stressors. If you have very kind of high risk clonal hematopoiesis, so if you have large VAF, TP53 or PPM1D mutations, you really want to engage in a discussion with their solid tumor team about trying to sort of mitigate clearly kind of triggering or sort of favoring stressors, which often are these platinum-based chemotherapies. Avoid PARP inhibitors. There is now sort of solid it's a meta-analysis actually showing an association between PARP inhibitors and subsequent development of therapy-related MDS. And so in these patients, I do perform a baseline bone marrow biopsy, and I do usually repeat a bone marrow at least once in roughly a year's time to get a sense of what the clonal dynamics are, because just as important as the original mutation in VAF size is that sort of longitudinal dynamics of that clone. And if I see a rapidly expanding TP53 mutation, I'm going to be very worried about sort of an imminent therapy-related myeloid neoplasm. And so in terms of approaching CCUS in the clinic, I really approach them very similarly to a lower risk MDS case. But again, I need to believe that the underlying genetic marker is causally associated with their cytopenias. And if the VAF is only 2%, I would be highly suspicious that their cytopenia is truly driven by that clonal population. Instead, we'll look for alternative etiologies. And so if they're lower risk CCUS, I'll ask that they return for a CBC at least every 6 months, possibly perform a repeat bone marrow biopsy in 12 months, or at least on annual intervals until there's clinical progression or stability. If they're higher risk CCUS, so a VAF above 10 to 20%, multiple recurrent somatic mutations, really, again, I follow them as if they have lower risk MDS in my clinic. Insurance coverage might be a challenge. So far, we have not had issues here. But I know in a number of countries that's a concern. How do you sort of diagnostically code these patients? How do you justify the investigations for higher risk CCUS? And then increasingly, I would encourage folks to send patients to academic clonal hematopoiesis programs for potential clinical trials, especially if they have higher risk CCUS. And so there's I believe a Danish study that exists where they're repurposing actually metformin for both lower risk MDS and CCUS. I've mentioned the 2 trials for IDH1 and 2 mutated CCUS that are running in the US, and I think soon will be expanded. And this is from internal data at MD Anderson, but there is now some preclinical data suggesting that rejuvenating delta gamma T cell and NK cell function might be actually important to preventing the progression of CCUS to avert MDS. Therapeutically, how to do that, we don't know yet, but I think that will be a fruitful avenue. And then the last bit of my talk will focus on the extra-hematologic consequences of clonal hematopoiesis, which again, from a population level, are actually much more important. This illustration here on the right is from a review that I wrote last year. And my favorite quote is, "Hematology is the study of blood and the tissue through which it flows," because blood cells are truly ubiquitous. They interact with every single tissue every single day. So it's not surprising at all that clonal hematopoiesis has a number of extra hematologic consequences. So far from preclinical work, the best sort of mechanistic understanding has been in TET2 mutated, TET2 mutated clonal hematopoiesis, which leads to upregulation of interleukin-6 signaling from affected monocytes and macrophages. And these monocytes and macrophages in turn actually invade into the vascular endothelium and accelerate expansion of those atherogenic plaques. And so, in terms of approaching mitigating these extra hematologic consequences, I think there's 2 major approaches. One will be, going after the clone itself, which I think is a bit more difficult, but lower hanging fruit is just going after the aberrant inflammatory signaling driven by these hematopoietic effector cells, and interrupting that inflammatory signaling might be enough in some cases to mitigate a lot of the extra hematologic consequences of clonal hematopoiesis. And so the point of this slide is really just to emphasize that at least for TET2 and DNMT3A mutated CHIP, detecting this is equivalent to picking up on any traditional cardiovascular risk factor if you look at the hazard ratio in this multivariate analysis for adverse cardiovascular outcomes. So it's really on par with a patient that's smoking a pack a day. And two things to keep in mind, though, is that the effect size is proportionate to clone size. And I would suggest clinically that if you have young patients or patients that really do not have traditional cardiovascular risk factors and are coming in with fairly prominent cardiovascular or even venous thrombotic events, I think it would be worthwhile to consider screening these patients for at least limited forms of clonal hematopoiesis in terms of the underlying etiology and potential intervention. And so I've mentioned how sort of interrupting that inflammatory component of clonal hematopoiesis might be the easiest way to mitigate a lot of these extra-hematologic consequences. Here are some potential candidates for doing that in terms of anti-cytokine therapy. Canakinumab, which is a monoclonal anti-interleukin-1 beta antibody. It was actually originally used in the CANTOS trial, and this was before this connection between clonal hematopoiesis and cardiovascular disease was known. But they ad hoc went back and looked at patients that benefited in terms of secondary prevention of cardiovascular events following a myocardial infarction. And the patients that benefited most in terms of preventing subsequent cardiovascular events were those that actually had TET2 mutated clonal hematopoiesis. And low-dose colchicine likewise has been shown in, again, in the absence of selection for clonal hematopoiesis to be effective in secondary prevention for cardiovascular events. Vitamin C is an interesting thought. There's a lot of preclinical data showing that vitamin C can actually restore aberrant TET2 or TET2 loss of function. So that might be a thought, especially for TET2 mutated clonal hematopoiesis. So I've touched a little bit upon the sort of clinical or logistical barriers to actually studying and intervening preemptively upon high-risk clonal hematopoiesis. And the main issue is we still lack truly high fidelity sort of risk of transformation models. And what we have right now is quite rudimentary. Next is that it's possible if we try to intervene on clonal hematopoiesis that we actually might lead to even worse outcomes in terms of driving resistance or emergence of even more resistant clones. And the other thing is that clonal hematopoiesis is not necessarily all bad. And there was a very interesting presentation at this past year's ASH general meeting in which there was a protective association between clonal hematopoiesis and actually Alzheimer's disease. And moreover, it is thought that at least certain forms of clonal hematopoiesis actually might be essential to maintaining the pruned hematopoietic stem cell pool in the very elderly population. So we have to watch to not cause unintended consequences by intervening. And last but not least, it's quite an uncomfortable sort of space for oncologists to be in terms of intervention outside of things that can just be cut out. And so I think we're gonna have to grow more comfortable with that as the study in this field advances. So some closing thoughts to take away to the clinical space is one, the vast majority of patients you see with clonal hematopoiesis will never develop a hematologic malignancy. So I think it's very important to communicate that to patients to avoid unnecessary anxiety and resource over-utilization because somatostatism is a part of life and is found in every tissue, although there are some unique aspects about that being found in the hematopoietic tissue. I cannot emphasize this enough, that risk stratification is essential, although we're still in the process of building high fidelity risk prediction models. And when in doubt, the best thing you can do is just to repeat the CBC and resequence that mutation and then look at the clonal dynamics. And that often will kind of give you a sense of where this is going in this patient. And then last but not least, be very clear with patients about what is and is not within our or their control, and be clear based on sort of their specific subtype of clonal hematopoiesis, what's the clinical outcome we're hoping to mitigate by continuing to follow them, even potentially intervene